Let's shine by seeing the best in all of us and by looking out for each other. Let's stay healthy. Let's shine together.
Hi, and welcome to Let's Talk Together. And today we are talking about early signs of heart attack. And our guests today are Sharol Plasterer and Denise McDaniel from the Reed Heart and Vascular Center. Welcome, ladies.
Welcome.
Thank you.
And before we get started, can you share with our community how long you've been at Reed and how you became interested in your field?
I can start.
Okay.
So Sharol Plasterer, actually started at the hospital in 1984, a few years ago. I worked in critical care, transitioned over to the heart cath lab and vascular center in 2003, and I've been in management there for like the last 6 years.
Okay, and Denise?
I've been at Reed in the cath lab for 8 years. Prior to that, I did bedside nursing on like a cardiac progressive care floor. So this is my first diagnostic area to work in, and I love it. So.
Oh, great, and welcome, ladies. We want to start off with why we're talking about heart attack, as well as I understand that the heart issues are the number one cause of death in America.
Yes, they are. It's really amazing. Most people think that cancer is the number one leader for mortality in the United States, but it's actually heart disease. And that encompasses not only heart attacks, but stroke, hypertension, other disorders too, peripheral vascular disease, in addition to kidney failure, that type of thing that's related to high blood pressure.
What's some of the, looking at some of the data about 85% of heart damage occurs within the first 2 hours from a heart attack.
It sure does. They say that according to the CDC that there were over 805,000 heart attacks last year, and that's roughly one heart attack every 40 seconds. And if you think about that, that's a really daunting statistic, I think. And so we want to make sure that people, number one, they recognize symptoms, they understand their risk factors, they seek medical help early in order to decrease that 85%, because you don't want to sit around at home experiencing heart attack symptoms and not seek medical attention.
One of the things often, I know one thing people mistake, it's like, oh, I think I just have indigestion, but really it's a possible heart attack?
Absolutely. So there are different signs and symptoms of heart attack, and we do have a slide for that.
Okay.
I put these in alphabetical order. There are some things that can be controlled and some things that we cannot control. Age, we cannot control. As we age, our bodies just go through changes. Diabetes, that's something that if you are a diabetic, you can control that. Diet, that's a controllable risk factor. Your family history, unfortunately, is not. If you have a positive family history of heart disease, especially at a young age, say your mother, father at around age 55, 65, that is early onset of heart disease. You are at a higher risk for developing heart disease if you have a family history. Gender at birth, that's something that, whatever your sign. Now, women generally develop heart disease a little bit later in life, but usually by the time menopause, we've kind of caught up with the men.
Before, I wanted to stop you on that family history part, and because we live in more smaller areas in our service area, so often people, because they're like, oh, their whole family has died of a heart disease or they had cancer or whatever. Maybe it's more profound because we're a smaller community. So Is that a tendency, but what we like to do is have people come in for screenings.
Right, absolutely, absolutely.
To
And
identify that.
Sure. And so, look at your family history, and if you do have a, mother, father, brother, sister, grandparent that actually developed heart disease early, there is screening available. You can get a cardiac screening, $29. Quick in, quick out, it's non-invasive, very good early test to determine how much calcium is actually in your arteries and are you at risk for maybe developing more cardiac disease or even a heart attack.
And also, from with family history, we started something last summer that we will provide information at family reunions. So often people say the only time they see their family is at a death.
Yeah.
So during the family reunion, we were setting up information stations on the various screenings and with your family history. So hopefully we're going to go out and do more this summer. I'm sorry, back on then with gender.
Yes. So, women generally catch up with men right around the time of menopause. And then as far as, I don't know if you can go back to the slide that has all of the different risk factors on it. Yes. So, of course, high blood pressure. The higher your blood pressure, the more stress it puts on your heart. And a lot of people don't even realize that they have high blood pressure. So, even like getting screening, just at like, at the hospital in the lobby, you can get your blood pressure taken and take that into consideration. Take those numbers to your primary care provider and recognize that you might have to be on more than one medication in order to control your blood pressure. High cholesterol, that's another risk factor. As the cholesterol builds up in our body, it can actually deposit fat and the cholesterol plaque under our arteries, or in our arteries under the wall. Illegal drug use, that can contribute to spasm within the artery. Obesity, sedentary lifestyle, smoking, those are all things that we pretty much know. Stress, that's a big thing. In fact, most people have a heart attack on Monday as they're getting ready to begin their 5-day work week, so the increased stress. And then the last one, that's something new that I actually learned about just last year, was your sleep pattern. That people that have interrupted sleep pattern or they don't get enough sleep are actually at a little higher risk for developing heart disease. So that's a new risk factor.
Wow. That I find that curious on the Monday morning.
Yeah.
With the stress level. So.
Yeah, I don't know that we necessarily see that in the cath lab because we, generally will treat patients pretty much all through the week.
Yeah.
So I don't know that we've ever done like a retrospective study to actually verify that, but that was just something that came from the CDC.
And I think our next slide is showing us about with plaque around the heart. So you want to
Yeah, so
elaborate?
yeah. So a heart attack is basically cellular death of the heart muscle. Myocardial infarction is another term for it. There's multiple etiology or causes for that. Anything that kind of puts stress on the heart. So even COVID caused some people to have heart attacks, not necessarily because of plaque buildup, just because of the virus and the actual stress on the heart. We're primarily focused today on looking at that plaque buildup. So in this slide, we can see that there is plaque, and it actually builds up between two layers within the heart, coronary arteries. So the plaque kind of sits underneath of the skin or the intima, but above the muscular portion or the media. And so as the blood is rushing by that, it can actually shear that cap off of that plaque, and the plaque then spills down into the distal circulation or the tiny little fingers that branch off of that large coronary artery. But what happens then is the body recognizes that as a break in the integrity of the skin, and so it actually, just like if we were to cut ourselves with shaving, you're going to clot, and that's basically what happens inside of that coronary artery. The platelets get activated, they grow a spiny process, and they kind of clump together, they catch those red cells, and the whole clotting cascade begins. And so that's actually what causes the disruption in the blood supply downstream in the heart. It's actually a normal response, but it is kind of overgrown or overdone because the plaque or the clot actually then blocks that coronary artery and disrupts the flow downstream. We can see here that that plaque ruptured, the clot formed, and now the tissue that's down below that clot is not receiving oxygenated blood, and so that myocardial tissue is actually dying. And this is what's actually causing the symptoms for the patients.
And our next slide has more on the heart attack, the signs and the symptoms. You can share with us on, for instance, chest pressure, pain.
Right.
Shortness of breath, nausea, vomiting, feeling like an impending doom, indigestion that's not like relieved, chest pain that radiates to your arms, your jaw, your neck, that kind of stuff.
And those signs, are they different in men and women?
Yeah,
Women
sometimes.
and diabetics usually have like different, like show with different symptoms. Sometimes they'll just have like general pain and, you know, not being able to, I'm going to let you come in on this too. So, you know,
So it's not
they
like
don't
on,
have, it's
on
not the
TV
same
shows?
symptoms all the way around.
So it's not like on TV shows
No.
where
Right.
you cut your chest
Yes.
and you're already aware.
Right.
So
That's generally the men. The men tend to have more chest pain, jaw pain, that type of thing. Women, because of our hormones, we have a little bit different pain. So we might have some epigastric pain or some indigestion, those type of things. And a lot of times, women will wait at home thinking that it's something else and not think of a heart attack. And so they end up getting symptoms from the secondary problems that would occur with a heart attack, such as shortness of breath or syncope or passing out, dizziness, those type of things.
that's always, I think, moving into healthcare, that was probably one of the biggest surprises. Well, that's not what I see on TV, and they
Yeah.
cure everything in 10 minutes. So that was like a big change. So what you're saying is basically the faster you call 911, the better.
Absolutely.
Yep. Also, really important, call 911. Don't try to drive yourself or don't have your family member drive you to the hospital. People die from just doing that. So, like, it's really important that you call 911.
As well as you are seen quicker when you're coming
Right.
through the ambulance.
And they can, like, go ahead and, like, they'll get an EKG. They can give you aspirin and, you know, oxygen, you know, stuff to, like, I don't even...
because they're
It
trained
helps to-
professionals.
Yeah.
Right, absolutely, absolutely. So they can
Your
ease
neighbor and your spouse often aren't.
Right,
So.
ease your pain. The nice thing too is that EKG that they're going to do can be transmitted to the emergency room physician. He can look at that and say, based on signs and symptoms that are reported and the EKG, this patient is having a heart attack. And so they can actually activate the cath lab team early. So let's just say, you know, the patient's still 20 minutes away. So that kind of has saved 20 minutes of that patient's time and heart muscle.
So that they'll know.
Right.
On a couple things we have, I always say that a lot of times the best way to explain it to our communities are we've worked together before, and the ticker trivia. So some of the points that you bring up, we can share. Some interesting parts with the discoveries of the stethoscope, I remember that. Just on the different discoveries and how that's helped with heart health.
Yeah. So, so what Sherry's referring to is what we did yesterday, which was Medical Monday, and I had a great turnout of women, and some gentlemen were there too. I tried to make it a little interactive, and so we kind of just shared some little tidbits. One of them, and I think that the audience did really enjoy it, was because back in like 1816, I believe, there was a physician, a French physician, that actually developed a stethoscope, and of course it was a true false, and of course everybody held up their little true paddle. But I asked why did he do that, and I think the audience got a kick. The reason why is because prior to the invention of a stethoscope, the physician had to actually put his head, an ear upon a woman's bosom, and he felt uncomfortable doing that on his well-endowed patients, so he developed something that he could step away from there. So that's how the stethoscope became invented. So Dr. Forsman was the first one to actually introduce heart cath, and that was, I can't remember, it wasn't that long ago, but I'm gonna say, do you remember what the date was?
Was it 90? Was it 90?
No, that was
that was when we started doing casts at the hospital.
I can't, it was, later than 1800s, but anyway, so there was a gentleman, he was a physician, a radiologist. He put a catheter in his arm, he ran down 2 flights of steps, he injected contrast or dye in that arm, took an x-ray. He was kind of the first one that was credited for developing a heart cath. Unfortunately, the hospital got wind of this, behavior that he did, which was not appropriate, and so he got fired. But then 2 years later, he won the Nobel Peace Prize in medicine. So that was kind of just a little funny thing. But we did talk about a lot of serious stuff too, and I think that the audience really had a good takeaway with signs and symptoms, and being very proactive in getting treatment.
As we have some, I think we have a.
Yes, absolutely. So this is just kind of a
tool.
yeah. We had lots of little stuff that we use in the cath lab. Some of it's a little tiny because coronary arteries are very tiny. I would say the average is maybe 3 millimeters.
Yeah.
We can treat 2 millimeters up to roughly 5 or 6. But I would say the majority of people have 3 millimeter vessels, which is really pretty small. When I came to the cath lab, I thought my arteries were the size of a pencil, but they're not. Probably the pencil lead. So this is just basically looking at just a normal coronary artery. Basically any artery in your body, there's 3 layers. But it just kind of shows you as that plaque is developing, you're getting those streaks, and then it just becomes thicker and thicker, and this patient, then you can see that there's a big loss of lumen, or the interior opening that's actually feeding oxygenated blood to the myocardial cells. So this patient probably would need to have a stent. So basically what they would do is they would take a balloon, it compresses the plaque up against the vessel wall, they deflate the balloon, pull that out, and then they put in the stent. The stent is basically like a metal scaffolding. It is compressed on a balloon. When the balloon inflates, it pushes that stent into the vessel wall. And so this is just a plexiglass, I don't know if you can see that, but that's just basically a stent. It's like a little wire scaffolding.
So, which was real amazing, because you hear about, they received a stent, they received a balloon or whatever, and you're expecting to see this huge thing, but actually it's very tiny because it's going in your body.
Yep, your
So
coronary
that's
arteries are tiny, yeah.
always interesting. I think we have another slide that showing some, I think it's just putting your balloon.
Yeah. So this is basically a patient that actually came in and they were actually having a heart attack. And so Denise can kind of show you.
Okay.
These are the pictures that we take during a heart cath.
I think this is a right coronary artery. It just kind of looks like a nub there. So the catheter's in there, and we just took a picture, and it's just showing what's there. I don't know what the next slide, there's a wire, we put a wire in to kind of, I don't want to say bookmark, but that's what we slide our balloons. It's a monorail system, so the balloons and the stents go over that wire. So once we get that wire into position, you can see that the vessel is opened up a little bit just from placing the wire. And then that is a balloon or a stent, I'm not quite sure. That's inflated, so we use a inflation device to blow up the balloon or the stent, because the stent's also on a balloon. Then when that comes down, so there's the vessel, when the wire, when we just had the wire crossed, and then the B side is, I'm gonna say that was a stent. Once the stent was placed, and now the vessel's open and blood flow is returned, so.
Are there often things that you see on a daily basis, not just something unusual, but something that's more common, some issues with the heart or the people that come to see you, in addition to needing a stent or something? Some are more common than others?
Well, whenever we do get a lot of students that come through our area, not only like nursing students, but we have pharmacy students, we have Seton School students, so we get a lot of students that come through, and I like to make everything, very simplified. So I always tell people, well, we have plumbing and we have electricity. So the plumbing part is the coronary arteries, the stents and the balloons, and then we have the electrical portion, which is basically the conduction system. And so we do a lot of electrophysiology studies on patients that have palpitations or they have atrial fibrillation, which is a very common disorder, especially patients that have sleep apnea, or even bypass patients that have had bypass surgery. It kind of disrupts or it kind of causes that enlargement in the atrium, and so they're more prone to have atrial fibrillation. So we also do our Watchman device, which is a left atrial appendage. We started doing that in 2017, and now we are, I don't know how many, in 2017, I think we did 2 a day, and now one physician can do
There's
5 or 6.
Yeah.
And be done by 3 o'clock.
Wow.
So, and this is really nice because the device sits in that left atrial appendage, which kind of hangs off of the top portion of the left side of the heart, the left atrium. For patients that have atrial fibrillation, the blood kind of swirls in that appendage, and then what happens, it'll clot and it will come out, and then unfortunately that's what causes a stroke. It shoots out up into the head. So I always say, what if you're a rodeo clown, or you're a police officer, or you like extreme sports, but you develop atrial fibrillation. So those patients have to be on an anticoagulant just because they're at a higher risk for stroke. So you would have to give up your livelihood. You couldn't be a police officer. You'd have to have a desk job. You couldn't be the rodeo clown. You couldn't do your extreme sports. So with this device, which we started implanting in 2017, now they're able to do that because the device sits in that appendage, kind of seals it up. It doesn't cure your disorder, meaning your atrial fibrillation, doesn't cure that dysrhythmia, but it allows you to come off of your anticoagulant. So then you do not pose a risk for bleeding and stroke. So.
And take us through the steps that for early heart attack care once you're admitted to the hospital.
So, once you call 911 and the ambulance picks you up, they do the EKG, they submit that to the hospital. So again, ahead of time, they're aware that you're on their way and they can activate the cath team. So our cath teams have 35 minutes to get the patient into the room. So generally we'll probably be there to pick the patient up. So we bring them upstairs to the cath lab. Move quickly, get them on the table, get them prepped and draped. We get them, attached to our EKG. Get them all draped and ready to go. The cardiologist or the interventionalist comes in, and then we just get to work. I don't.
It's a well-oiled machine. This team of individuals that we have is phenomenal. So the national standard is door to balloon. So the time they present to the emergency room to the time that the arteries open, whether that be a stent or they aspirate a clot out or they put a balloon up there and they inflate it. The national average is 90 minutes. That's what we're all working towards. And I think that our last quarter we were right around 53.3 or 54 minutes. So that's the best time that we've had in years since we started tracking it. So this is a very high-functioning, well-oiled team. I will tell you that, and I always get choked up when I tell people about the staff because they're just phenomenal. They work so well together. It's almost like a dance when you watch them. Everybody knows what they're to do, supposed to do. Everybody reacts appropriately. They all have great critical thinking skills. I mean, just very proud.
We're glad they do. The other thing is, so I was confused on. So within your department, I know I just know that you're all part of the cardiology team. There's different areas.
Yeah, so
Okay.
it's Reed Heart and Vascular.
Okay.
So we have 4 labs. So we have our inpatient lab that we do generally the emergency room patients in, as well as inpatients. Then we have an EP lab, so they're the ones that do like all the electrical, so the conduction stuff. Then we have an outpatient lab where we do heart caths, we do stents over there also, but it's not on an emergent basis. And these patients generally come in, they're healthy, they're walking, talking.
So
versus the ones
they've been able to schedule that.
Yes, absolutely. They might have an abnormal stress test, or maybe their calcium score was high, or maybe they've had a stent in the past, and now they're having more symptoms that could lead us to believe that maybe the stent's clogged, or maybe they have more disease. And then we also have a vascular lab, and the vascular lab is actually over in the OR, in the operating area, and we do a lot of peripheral vascular work, carotids, stents to the legs, and then also we can do our TAVR over there, which is trans-aortic valve replacement. And Denise is actually the lead nurse on the TAVR team. And then what else do we do? A lot of cool stuff over there. We do a lot of PE work too, so pulmonary embolism, which especially during COVID was very relevant, and we had a lot of patients that had PEs, as well as stents clots in their legs, so DVTs.
What would, this question is for both of you, what would you like our community to know the most about heart health? And what would be number one or two things that you'd like them to know?
Number one for me is call 911.
Yes.
Okay.
Don't try to have your family member drive you to the hospital.
Right.
It could save your life.
Absolutely,
Literally.
absolutely.
Time.
Yes.
Time is
Time is
huge.
Time is
Muscle.
muscle.
Okay.
Yes, and a lot of times when patients do, when they do die prior to coming to the hospital, prior to arriving at the hospital, it's because of a lethal arrhythmia. So the EMS is prepared to deal with that. They have a defibrillator, they can defibrillate the patient, they know how to do high quality CPR. So they are, your heart attack care occurs before you actually get to the hospital. So yes, make sure that you're calling 911. Recognize your symptoms and make sure that you don't dismiss them.
So my takeaway is make sure that you use 911.
Yes.
Not necessarily arguing with your spouse or significant other,
Right.
what we should do, but just do it.
Yes.
Then that's the safest measure.
Yep,
That
absolutely.
we would have. Well, I want to, as we wrap up, just want to thank you both for joining us today on Let's Talk Together.
Well, thank you. We appreciate you having
thanks
us.
for having us.
Oh, great.
Thanks,
Thank
Sherry.
you. And thank you for joining us today on Let's Talk Together.
Let's shine by seeing the best in all of us and by treating you here, right in your hometown. Let's look out for each other. Let's stay healthy. Let's shine together.